So you go to the operating room, what happens then? Well, you're given a sedative, local anesthetic in the scalp. The brain has no pain receptors. The bone has no pain receptors. So you have to numb up the scalp, and you have to numb up the meninges. That's the only time you're going to get any pain from this. Blood pressure, we like to control it very strictly. We don't want any elevations in blood pressure that can lead to hemorrhage and bleeding. So we have anesthesia control the blood pressure. There is a 14 millimeter Burr Hole that's made. We have a standard perforator size. The reason why you make a 14 millimeter Burr Hole is because the anchor that locks the electrode to the skull is that size. So it all is made to work together. And that's made with a drill, kind of a scary sounding thing, but doesn't hurt. This is the stereotactic frame that gets put on in the operating room. It's another component of that frame that gets put on your head. And there are numbers all over it. So there are numbers here, there are numbers on the side of this ring structure here, there are numbers on the Z bars, and there's numbers on the frame. That's where we get our X, Y, and Z coordinates, but you also get an arc angle and a ring angle from that. And that's how we localize the target. So in the operating room, it looks sort of like this. Here's the patient here, here's that sterile ring frame on there. We use a C-arm fluoroscope across there for two reasons. One is to keep the drapes off your face, which is nice, so you can see. Dr. Andriola will stand on the other side. I will stand back here. And the second thing is, as we're tearing things down and taking it apart and removing things, we keep taking x-rays to make sure we didn't undo all our good work that we did in there. We want that electrode to stay in that same position. So that's why we have the x-ray in there. And this is a micro drive. This is what advances the microelectrode that we're using. And it can move in increments of 1 micron, which is about 4/10,000ths of an inch. We don't go that slow, but we could if we wanted to. So it's a very, very precise instrument. The microelectrode recording gives us, again, an electrical signature. And I'm not going to have you all become EEG techs in here. Basically, as the electrode goes through, you can see that there's a pretty dramatic change between this border zone here and the subthalamus there. And then when you go through, there's another change down here. So we can plot out where we are. And what we like to see is we like to see at least 4 millimeters through the subthalamic nucleus. If we get 6, we're very happy, because you're going to have 3 electrodes in the subthalamic nucleus that are usable. If you get 3, we're probably going to do another pass, and we're going to guess, make our best educated guess in which direction to move this electrode. We move it 2 millimeters at a time to try to get the best possible localization of that electrode. This is a video that came from a PBS Wired magazine special on this, and it's available on YouTube if you want to look it up. But I just want to show you how small the microelectrode is. It's finer than a human hair. And this is the electrode that stays in place here. So it's significantly larger than that, but still very, very small. And so I just want to show you size. There's the microdrive that it fits down. Okay? And again, I mentioned we do this as a multi-stage procedure. There's 2 reasons for that. Biggest reason is that most people with Parkinson's disease are very uncomfortable off their medications. So to try to do both sides at one time is usually very difficult. As you're doing the second side, it gets squirrely. A lot of Parkinson's patients have neck and back problems, so laying on that table for 4, 6, 8 hours becomes very difficult. So we prefer to do the 2 sides separately. The other thing is that a lot of locations that do the bilateral procedures have a very high rate of postoperative cognitive problems, confusion, memory loss, seizures, everything that we've been able to avoid by doing it separately. We really have, I don't think we've had any patients that have had any postoperative cognitive problems. We've had 1 patient with a seizure after this, and other than that, it's been very smooth. The other issue is that the brain part is done with you awake, and the batteries are done with you asleep. So that's why we separate that out. And there are some economic issues about how this gets paid for and so forth, where the batteries are done under general anesthesia and you go home that day. So with the brain part, you stay overnight, go home the next morning. With the batteries, you go to sleep, batteries get put in, and you go home that day.